child can have a situation which is, both the alleles are affected by the mutation, and therefore the child can get thalassemia major.
A man who didn't just practice medicine, he built an entire ecosystem of care. Hello, viewers. My name is Japishman Kaur. Welcome to our podcast today. I'm truly honored to be in conversation with a great personality whose dedication, compassion, and years of service has touched countless lives and brought hope to so many families. Today, we have with us Dr. M. Joseph John, Professor and Head of the Department of Clinical Hematology and Bone Marrow Transplantation, and Associate Director at Christian Medical College and Hospital. Sir, we welcome you and we are very grateful for your presence today. With your achievements speak for themselves, I believe no one can share your journey better than you can. So please introduce yourself to our audience.
Thank you, Japishman. And I work at Clinical Hematology Department at Christian Medical College, Ludhiana. And I had the opportunity to come in 2007, establish as Department of Clinical Hematology. And we did our first transplantation in 2008. That was the first allogenic transplantation in Punjab. And since then, we have been doing regular transplants, and we have crossed almost 300 plus transplants. I am blessed with a good team of doctors, physicians, and nurses, without whom this program cannot run. And Japishman, you have been one of those people who have been with us in the past. I'm so privileged to be here today.
Thank you, sir. Yeah. And why did you choose blood disease as your specialty? Like, was there a special moment?
Yeah, so honestly speaking, during our MBBS MD time, there was not much of blood disease treatment or blood cancer treatment in 1990s. I wanted to be a neurologist actually. But because my mother and my grandmother had studied here, I had made a commitment that after my MBBS MD, I will stay back. So it was during my MD time, somebody said, it's good to be a neurologist, but we do not have blood specialists here, and we need to start a transplant program here. So it took me about a year or year and a half to make up my mind, and I started reading and discussing with people, and I said, okay, it is a challenge which I can take up. There is a possibility of failure. But that was the reason actually I switched to hematology and then gave the entrance exam at CMC Vellore. So nobody was doing training hematology at that time in Punjab or beyond Delhi. And neither transplants happened. So that made me think through hematology and go to Vellore and get trained and come back.
So inspiring. And what was your education like from scratch?
Okay, so I did my schooling and my pre-degree, those used to be called +2, in Kerala. So I gave my exams in many places. When I wanted to do medicine, my mom studied here and she was an inspiration to do medicine. So I got into CMC Ludhiana first, followed by back in Kerala. Then my dad said, no, you got in Ludhiana, just be there, don't come back. So I continued to be in MBBS in Ludhiana. That is how I reached Ludhiana. But it had I also then was honored to say that, okay, my mother and my grandmother studied here, and therefore it will be the third generation here. So that was another reason why I took up medicine and been here.
When you were in Ludhiana and there was nothing set up here for the treatment and all, how did you start that from zero? It might be difficult now.
Yes. So yes, it was tough. That time the mobile phones had just come up, and therefore that helped me in connecting with people and get the communications through fast. Otherwise, it used to be trunk calls and STDs. So this mobile phones became very handy at that time, because so many things have to be thought through, because nobody understood the language here. So while I was in Vellore in my last 6 months, I requested the administration here to send off a blood bank technician, a laboratory technician, and a nurse to Vellore. So they were with me for about 6 weeks, during which time I could get them an orientation. But here I had to start off with training almost everybody, including the sanitation worker, how to sweep and mop the floor.
It is
So
actually motivating.
it was tough, but it was fun because everybody worked from the heart, wanted to set up something new and different, and I have some of the pictures with me which I can share sometime later.
Nice journey. And like we are talking about the thalassemia, and many people don't know what exactly thalassemia is and how it is diagnosed. So please tell them that how it is diagnosed and what exactly it is.
So you touched upon a very important question in terms of I would be happy to tell the viewers here because thalassemia major is completely preventable. One, provided we know the thalassemia carrier stage. Now, thalassemia is a situation where imagine our red cells are produced. We have half the genes coming from the mother, half the genes coming from the father.
Hmm.
This is a gene which is only half is involved. There is no symptom in the parent, so they won't know it. So if both the mother and the father are carriers, then the child can have a situation which is, both the alleles are affected by the mutation, and therefore the child can get thalassemia major. Now, thalassemia major is a situation where, as I said, the genes which produce the red cells are defective, and therefore abnormal red cells are formed and not able to give the necessary oxygen to the tissues, and therefore growth retardation, etc., can happen. So this can be completely preventable if it is an arranged marriage, especially if you can do the HPLC, it is some 800 rupees test, which can be done. It is a blood test which can find out that it is thalassemia carrier or not. And with an arranged marriage, avoid marriage between two thalassemia carriers. If it is a love marriage or after marriage, you are finding it out. When the mother is pregnant, you can actually test if the baby is affected or not. If they are affected, then continue for abortion. Now, if you don't want to do abortion and the baby is born of thalassemia, we have cure can be done by transplant or maintenance can be done by transfusion chelation. Both are options. Transplant is essentially curative here.
And at what age it is good to have a transplant?
Yeah. So by and large, we would like to do the transplant at an earlier stage, which is somewhere between 2 to 9 years is the best golden. 2 to 7 years is the golden time. We can extend up to 12 now because we have better conditioning regimens available, and that is that's effective because side effects are less. It is not that after 12 we cannot do. We have done up to 20s, early 20s, that and late 80s, 18s, and the 16. They're doing well. Complication risks may be higher. So golden time 2 to 12. Best is 2 to 7.
How many changes have you done? How many cases have you fought for it? Like,
Right. So the denominator is very difficult to ascertain because there is no registry program in the country as of now or Punjab, but there is a lot of effort being done. As a thumb rule, we say about 10,000 children are born per annum in the country. That is because about 3 to 5% of Punjab population is thalassemia carriers. So the probability is there. 10,000 across the country. In Punjab, maybe about 100 to 200 are born per annum. Now, what have we been able to achieve within this? Our space is essentially for transplant space, but we do have a lot of awareness programs created in terms of thalassemia screening programs, and it is at the moment best. So we had done an ICMR project from our institution earlier to look at all the college going children to do thalassemia carrier state, but that did not come to fruition because still there is a stigma in India, especially in Punjab. If you say my son or daughter is thalassemia carrier, nobody will give a spouse. Therefore, to tell that to the community is tough. I must tell the viewers that absolutely no problem. Thalassemia minor is as good as a normal person, nothing will happen. So even if your prospective spouse is a minor thalassemia minor, whether a girl or a boy, both are acceptable, and you can have a perfect marriage life if one of them is not a carrier. I mean, only one is a carrier and both are not carriers. If both are carriers, there is a 25% risk of the child becoming a major. That is the only major disadvantage. So awareness among obstetricians have increased. I'm not saying it is perfect, but still we are thalassemia children are being born is because we are unable to counsel. I mean, it's not a foolproof mechanism as of now. I hope it will become.
Like, what is the difference between major and minor?
Yeah. So that's essentially three spectrum of patients. One is thalassemia minor, absolutely no symptoms. Thalassemia intermediate, there is some transfusion requirement, and thalassemia major, we will have to give almost a monthly transfusion or once in two transfusions in a month sometimes as the age progresses. So thalassemia major is a worry, intermediate is a concern, and minor is no problem. Only intervention is to avoid a marriage to another minor. So major, both the genes are affected, and therefore RBC production is a difficulty. That is where we need to do the transplantation. Now transplant is being extended to intermediate also, because the risk of transplant is coming down.
Is the exactly test we can do to know that the child is thalassemic?
Yeah. So thalassemia minor and major without transfusion. Before transfusion, you have to do the minor testing, the thalassemia carrier testing or HPLC testing. It's called HPLC testing. It's a blood test. It's about 800 to 1,000 rupees, different labs. The turnaround time is somewhere between 1 to 2 weeks, and you can get it in a HbA2 is a value which is elevated more than 3.5, and that says that it is a minor. Major is measured on HbF levels, and that's a different. But essentially, a small blood test can give you major or minor.
Isn't there any medicine discovered yet for the thalassemia student?
Unfortunately, there is no medicine as such. Okay, there is a gene therapy which is in the pipeline, which means that they take the patient's cells, modify it genetically, put it back, and that is in its early stages of implementation. Has not yet happened in India as of now, but research teams are working on it in India. No medicine as such to avoid transfusion. There is a drug called luspatercept which has come in that can defer or reduce the number of transfusions, but not prevent or completely avoid it. Right now, the cure is only transplant essentially.
Exactly, what is the procedure of transplant?
Okay, so transplant, understand that there is a donor and there is a patient.
Hmm.
The patient has a defective stem cells. Stem cells are cells which are in the bone marrow, that is in your long bones, the hip bones, etc. There is this bone marrow. That's a factory from which the blood is produced. The factory in which the red cells, the mother cell, is called the erythroblasts. So the DNA of that erythroblast is affected. That is producing smaller red cells which are affected. So you replace it with a normal donor, the stem cells, and now the stem cells are producing normal cells, and that's the whole process of bone marrow transplantation.
And what is the success rate for it? Like, is it?
Yeah, so success rate, if it is early age, as I said, 2 to 7, the success rate is somewhere between 90 to 95% of the patients would be thalassemia free or overall survival is good. As the age progresses, it's come down. So by and large, I would say 80 to 90%. But if it is more than 20, we would say about 70 to 80%.
And what are the biggest complications for the bone marrow?
Yeah. So when you do a transplant, essentially we are replacing a donor's entire immune system to the, replacing the patient's immune system from a to a donor's immune system. So problem number one, till it engrafts and starts multiplying, there could be risks of infection. Second is there could be problem of bleeding issues when the platelets are down during this problem. Third is the donor cells may recognize the patient cells as foreign and produces a reaction called graft versus host disease. And it's almost like a marriage. First 1 month it is hunky dory, everything is fine, but second month onwards the fight will start, and by about 6 months to 1 year they understand each other and the tolerance will develop and they continue normally.
Is that curable? The graft
Yes,
versus
it
disease.
depends. It is treatable, and that is something which is controllable. About 10% of them may have a long term problems
Hmm.
of GVHT, either chronic GVHT may happen, but over a period of time that gets resolved on its own. Acute GVHT is something which happens immediately, and that can sometimes be detrimental.
And how many transplants have you done till now?
So in our institute, we have done close to about 318 transplants so far. Out of them, about more than 100 and about a half are thalassemia transplants.
And like after transplant, how is the life?
Yeah. So the difference between a kidney transplant and a bone marrow transplant, that is essentially, and then you're asking the question, what is the quality of life of transplant? So generally, thumb rule, everybody's medicine will be over by 1 year. Some of them we may have to continue for longer period if there is GVHT or certain other complications. We'll have to revaccinate all the patients post transplant. So essentially, after about 2 years, vaccination is complete, and they are free to go to any place, anytime. And many patients have gone back to normal life, got married, had children also.
Is there any government support in financial things like bone marrow is not affordable for everyone?
Yeah, so that has been, we are blessed to have been one of the institutions who are recognized by Coal India, Ministry of Health and Family Welfare has collaborated with Coal India. Now, Coal India has CSR funding, corporate social responsibility. So they have now adopted thalassemia transplants, and we are one of those institutions they have supported. So per transplant, Coal India is now giving 10 lakhs if there is a sibling match or a mud transplant match. Veha Foundation, hearing about this, has come forward and offered another 5 lakhs for them. Tata Trust is anyway been supporting us, and they are also giving. So almost today in CMC, thalassemia transplant can be free, except for some local support which they may require to stay and food, etc. Which also there are some other organizations in helping out in some cases.
Nice.
There are some families who are scared to have this transplant and they're not sure whether to have this or not. Will it result positive or negative? So, what piece of advice would you give them?
So that is where people like you will come in play in terms of media to get this message across. There is a lot of apprehensions because somebody who did not get a good result out of transplant may have influenced some people, vice versa. So the message I will say is that if you have a 10 by 10 match in your family, you must go for a transplant. If there is a matched unrelated donor transplant 10 by 10, go for it. Lower matches also is now getting better. We are doing half match transplants for leukemia and other patients. But in thalassemia also now half match transplant is coming in vogue. So essentially everybody gets a match, but half match transplants are more costlier. So if there is a match available, I would strongly recommend going for transplant. Yes, it is a short-term risk, but a long-term advantage. Transfusion chelation, no short-term risk, but long-term risks are higher. So you are actually taking the balancing out the cost versus benefit in both these decisions.
As the major one gets the more complications. So, if it is a minor, do he she also needs any kind of treatment or transplant, or is it okay to be?
Minor patients does not require any treatment, and if they have any other causes of anemia that has to be treated, minor is absolutely fine.
And that's a personal question that between saving lives and running a department, also researching, how are you managing everything?
Yeah, so yes, it has its own complications or impact in the family time. Yes, we have had that conversations in our family. That is a sacrifice I would say the family has to do for a larger good. But now with more team members, I'm able to spend more time at home.
And what is the biggest challenge for you in this all program like transplantation?
See, the challenges are different in different phases. The initial phase transplant the challenges are different, whereas at this point, to sustain a volume of transplants and the necessity, the administration, the local support, the government support, all are there. So there are different levels of challenges, whether it is regulatory requirement, quality maintenance, whether it is financial requirement, societal impact. There are different challenges at different phases.
And how are you feeling to be in this position, serving like a great doctor?
Yeah, it's grateful. I'm grateful for the opportunity I got, and something which I can say that okay, I could do for the community, and that was one of my dreams of having to be able to contribute for the privileges I got.
Anything else that people are not aware of?
It is important to understand what is thalassemia, and to be able to understand the family about the thalassemia, the kith and the kin. And for the general public, thalassemia is not a taboo, you must think, and they can be embraced. Thalassemia minors can be married to, if you are a normal, and you will have a normal family life. Thalassemia major patients do go and get regular transfusion chelation and explore the possibility for thalassemia transplants. And I would say the general public who are listening to this, and the people who are well off and blessed in life with resources, give your some time and effort and finances towards curing children with thalassemia. And that if everybody in Punjab, 3.5 crores of 3 crores of population in Punjab, come together in this unified effort, and some of your tithes or donations can be set out for these patients, you can get good quality of citizens in India who can contribute to the productivity.
You find donor. So is that always from India, the family, or you also look that for outside?
So when we do transplants, we can either have a family donor. When a brother, sister, father, brother is not a match, then we can explore somebody outside. So when we say outside, people like you and me can sign up as donors. And if our stem cells match with somebody else in the country or abroad, we can collect the stem cells here, and the stem cells can be sent to the other country.
Is there any other place where the treatments are happened for bone marrow?
Yeah. So when we started the transplant program here, we were about 15th or 20th, and thalassemia transplants, we were about 4th or the 5th institution who were doing at that time. But now things have changed. When I was passing out, there were only 6 hematologists passing out. Now there are about 100 hematologists passing out every year. So people have moved out. There are about 160 plus transplant centers in the country today. In Punjab, however, it is only we and PJ who are doing the thal transplants, but mostly we've been doing thalassemia transplants.
So means that thalassemia transplant is actually a very good treatment for the people who are suffering from thalassemia,
Absolutely.
and it is a great program that you are running. And your work has not only served countless lives but also inspired many of us to believe that excellence and compassion can truly transform healthcare. I know your time is extremely valuable, so let's just end this session here. And it was a great experience and a great day. Thank you so much.
Thank you.